Okay, so for my first side cue, in patient with spondylolisthesis, post-surgery spinal fusion of L5 and S1 who is suffering from joint stiffness on the entire back and limitation of motion, how you might need to modify your interventions for this particular patient to follow precautions. So my answer is, to follow precautions, patient should prevent excessive initial mobility or stress on tissues, and patient should avoid lifting, twisting, or bending of the spine for 6 weeks. I'll make sure that the interventions or treatment plan given to the patient is not that hard and tiring to him, and also make sure that the exercises are doable for him. I will use easy and safe treatment that could not intervene with the restrictions in order to observe the precaution in his condition. Next, side Q, what movement is contraindicated for a patient with post-op ACL reconstruction using an allograft semitendinosus during the maximum protection phase? What intervention is best for the patient's recovery? Pivoting on the surgical side is contraindicated in max protection phase. Interventions will include swelling management like cryotherapy, retrograde massage, and ankle pumps. Next is for ROM or mobility like patellar mobilizations, seated assisted knee flexion extension, and heel slides with towel. Low intensity, long duration extension stretches, standing gastroc stretch and soleus stretch, and supine active hamstring stretch and supine passive hamstring stretch. Last is for strengthening like calf raises. Last is for strengthening like calf raises, quad sets, NMES, SLR, and multi-angle isometrics. Next side Q, one of the common complications of TKA with an unconstrained approach is joint instability. What do you think is the contributing factor, and explain why? Unconstrained approach doesn't have the effects of the elements of the knee implant design that provide stability needed to counteract forces about the knee after arthroplasty in the presence of a deficient soft tissue envelope, which is why it's unstable for me compared to the other approaches, and this is one of the factors why it causes joint instability. So side Q number 4, in THA anterior approach, what precautions should be followed? Provide 2. Number 1, do not cross your legs. Use a pillow between legs when rolling. Number 2, do not allow surgical leg to externally rotate. Okay, side Q number 5, post-op THA cemented posterolateral approach maximum protection phase. Weight bearing status training to 50% PWD from NWB phase 2 weeks post-op in progressing to moderate protection phase. What criteria should the patient achieve and why? Provide 2. First, ability to bear full weight on operated extremity without pain and with a fully extended knee. Second, independent level ground ambulation with one crutch or a cane or no assistive device if weight bearing restrictions permit. Thank you.